welcome to the Zoom meeting. So today we will have a really hopefully helpful meeting. So Dr. Mayra will lead the Zoom meeting. Please.
Hello, good afternoon, everybody. This is Mayra Mezzoni, and we are the Line group. And I hope you guys enjoy this presentation. For the first presenter is going to be, I think it's Dr. Sushma. So she's going to speak about her project that presented on a conference. Whenever she's ready, we're here for you.
While she's taking her computer or on the mic, Dr. Sushma and her team presented one of our abstract in the bike conference. So I asked her to briefly give you her experience. So while she's preparing, maybe we can also listen to Dr. Mulham. Dr. Mulham was one of the fellows in the fifth batch in this group. And so why don't you, we welcome you back and like to have you give us some input. And then when Sushma, she can join after Dr. Mulham. Dr. Mulham, go ahead.
Hello, Dr. Nader. How are you doing?
Doing great, thanks. How about you? How's the residency so far?
You know how residency is. It's crazy.
Thank you so much for your time, and it's up to you. Go ahead.
Thank you for giving me this opportunity. Thank you. I'll try to share my screen. Not sure if my screen is clear.
Yes.
Okay. Are you able to hear me and see the screen? Okay. Hello, everyone. So first, I'll introduce myself. My name is Mulham Ombada. I was fortunate enough to have the opportunity to be in the first group of the research fellowship with Dr. Nader. It was a great opportunity to learn a lot of skills which are needed during residency. That being said, today I'm going to present a topic which is important and not discussed as much, which is what are the things that we need to do and focus on after the SOAP process? Because there are things that can be done after SOAP which can increase your chances to attain an interview and hopefully match. So let's go through those strategies. So the most important part is contacting programs. And the best way to review programs is using a website called Frida. So that website is critical. You need to go through it and try to form the best sites or programs that is preferably going to work for you. So probably there's about 400 or 500 programs for internal medicine, maybe 250. I'm not exactly sure about the number right now, but those programs you need to review and see what are the best that works for you. Programs are divided into university programs and community programs. And as we go in slides, you'll be able to differentiate what are the parameters or factors that programs look for in a candidate regarding university or a community program, and what are they looking for in applicants regarding those programs. One important thing that's usually forgotten is there is a backdoor to residency, which is fellowships. So it's important to remember that we have nephrology fellowship, as well as geriatric, as well as ID. So due to the focus mostly on a couple of fellowships like cardiology, gastroenterology, hematology oncology, as well as POMCRED. So there's an opportunity to go to nephrology, ID, and geriatrics first, and then returning back to residency. Now, it's not easy, but it's possible. And I have seen a lot of people doing that process. So what is needed to be done here is contacting programs with an interest that you're interested in nephrology or geriatrics or ID, and they would review your profile and see if you're a candidate. And then they would provide you with an interview and hopefully match there. So that can be done right now up to 1st of July. And the best website is Frida. There's like one of its tools there is mentioning spots. So you can search for one of the spots there and get what are the available spots for nephrology, geriatrics, and ID. One good thing about also the website is they provide emails for program directors and program coordinators. So it's important to remember that if the website doesn't mention the program director, it means that the program director doesn't prefer to be contacted first. So the priority here is to contact the program coordinator. If you contact the program director in those situations, it's considered to be a red flag, and most probably they won't respond. And if they respond, most probably it won't be a good response in the sense that they're gonna place you in the red list or the blacklist in a way that they won't provide you an interview. So that's something that to be remembered. It's okay to contact programs, but it's also important to remember what are their preferences. So that's one way to remember, or at least think about it when you're going through the Frida website. An example of how will you place an email to programs. So it's going to have the subject, the content-wise, and the ending. So I just placed an example there. For instance, you can say something like the subject is a PGY1 position interest, or PGY1 position interest, which means that you're interested in a position there for a postgraduate year 1 as a resident or an intern. That is a good clue for them to see the email. Second point is content-wise. So it's important to summarize your CV and try to look towards the most important factors in your CV. What are the things which are shining? Like, is it clinical experience? Is it research? Or is it some other factors? And try to make that CV or a summary of it in that manner. If it is scores, mention the scores. Don't just mention step 1 or step 2 pass. Mention the score if you think you have done great there, as well as finishing step 3 is considered to be a positive factor in most programs. And not to forget the ending. You can end it in a good way, which is looking forward to hearing from you soon. And contacting programs can always build connections, even if it's not giving you an interview right now, but at least they are already reviewing your CV before the matching process, which means that you're going to have a more opportunity and a better review before most applicants. That's something just to consider. So what are the factors that programs are looking for? So there is no specific formula or specific way to know exactly what programs are looking for, but every program have their own successful formula, which is built up in many years. Some programs have been there, or program directors or coordinators have been there for about at least 20 years, 10 years, 5 years, regardless. What happens is they go through what they have been going through for the last few years, and they look into applicants exactly the same manner. If you look at the pattern there, for instance, if you go towards the websites and you're able to see the photos, you would notice that there's a similarity in the demographic of the applicants or the residents. So they technically go through the same process in terms of the demographic, one factor, score-wise, and other factors that they look into. So if they are an institution, for instance, a university, then their focus is most likely in an applicant which is more academic driven, because they want to make sure that they're going with their goal. So they need to be at least a researcher or having some interest in research activities, or having some roles in the past of teaching. So those factors are critical when you're thinking about university programs. Scores are always important, regardless in universities or communities programs, But there is always exception to the rule. The more you work on factors like, for instance, research or teaching roles, you kind of counteract that balance, as well as doing some more clinical experience. Community programs, they mostly focus on high scores and clinical experience. They prefer not to have a lot of experience in research, because whenever somebody's having more research experience or teaching experience, it means that they're more towards academic, or their future goals are academic, which means also that they are not going to rank the program or the community program as high. So that's an important factor for most programs. Whenever they're placing an interview for somebody, they are almost thinking that that person gonna rank them high. It's a priority for them. They want to make sure they get 100% success matching without going to the SOAP. Any program that goes into the SOAP is considered to be a bad, or a program that is considered to be not as successful as the other programs. So that's one thing that they're looking to. So what can we do regarding what we have? So always the goal is to polish our CVs, and there's a lot of things that we can do. So there are things that are done already, so we shouldn't be thinking much about it. Our goal is to work on what we can to make our CV polished and a bit exactly driven towards your goals, as well as what the programs are looking for. So we kind of discussed that in the university or community program driven, especially like mostly my referrals were towards medicine or that part, but it's also very similar in terms of psychiatry, pediatrics, and family medicine, because all they're divided into either university programs or community programs. So what are the factors that you can work on? First, see what projects you're already working on, publish them, have you mentioned starting with any journal that you can publish first, and then keep on going until you have a better impact factor journals, 10 and more. That's a goal. Second factor is involve more in presentations. So the more presentations you do, it means you're more mature. You're having a skill that is needed in residency, either as in a community program or a university program. So you can actually mention those during the ERAS application. For instance, all the presentations that you're doing here as a research fellow, you can mention them in a way that you are actually have been presenting such and such and such presentations. So that's important to remember. Other factor is working on your personal statement. It is not a huge factor in terms of determining applicants, but it's still a factor that sometimes when they're looking towards 3 or 4 applicants who have very similar CVs, they would just end up seeing this personal statement, seeing if the person is interesting. If you're interesting, then they'll be like, sure, let's give this applicant a chance or an interview. Clinical experience. So mostly it's for community programs. They prefer more clinical experience, the more you can. The number that I have seen a lot, and most programs they prefer to, is 6 months. If it's a recent grad, then usually it's like a 1 to 3 years. Oh, sorry, 1 to 3 months. That's what they look for. But 6 months within the last year or 2 at least, that's what they look for. And the better the program, or a program that has like training or residency training, is considered to be a better program rather than program, or let's say training in somewhere as in a clinic is considered to be good enough, but it's not the same as being involved in a residency program. The reason is, so if you're going to have an elective or observership somewhere in a program that is already working on multiple factors. So the way to think about it as a program, that you already have been trained or had a view or an eye in that program. So you already might know EPIC. So EPIC is, for instance, a system that uses to generate data, we review data from it and such. So they want somebody who's familiar to the system. And whatever they're doing in terms of looking towards the CV or looking towards publication and all that, one word is always critical. They're looking for the right fit for an applicant. So is this person fitting towards our program? And they expect you, well, the way you speak during an interview, is to formulate that. Whatever they are asking, they're trying to see, are you really fit to the program? And the question that you're asking should also be based on, are they the right fit for you? Now, last factor is letter of recommendation. So letter of recommendations are important, and you need to remember that the quality is more important than the quantity. But then again, you need to make sure you have the right number. For instance, if you're applying to a program that says 4, you need to make sure you have 4, but there should be quality. So it means that it's explaining who you are as a person, your qualities, your skill sets. Somebody who comes early and goes late, but at the same time, they are hardworking and willing to learn, regardless of anything that can happen. So it's important to focus on those parameters. Once again, research is important. The quality of the research is also important. Letter recommendations, the experience that you have, and the personal statement. Just going through it and making sure it's appropriate and explains who you are and your skill sets. And at the same time, it shouldn't be replicating your CV, because the CV is the thing and the personal statement is a separate thing, and it shouldn't be the exact replica. And trying to also work on the presentations and including them in your ERAS application. I hope this was helpful, and please ask me any question if you would like. Thank you.
Thank you so much, Dr. Mohamed. It's great, and thanks for the input.
You're very welcome.
Any questions for Mohamed?
Thank you
Go
for
ahead.
the presentation and all the tips that you gave us for the ones that we are in the journey of getting matched. Thank you.
Oh, yeah. Go ahead.
Hello, Dr. Mulham, and hello, Dr. Nader. I hope you're both doing fine. Actually, I have a question for Dr. Mulham. You mentioned something about the quality of the researches that we have to put in our ERAS application. So what exactly did you mean? Like, if I have something between like 3 publications or more, would it really matter if they were review articles or something like a systematic review or something like that? Does that really makes difference, or it's just important that I do have some publication in my CV? Thank you.
Thank you, Dr. Hoyam, for the question. That's a really good question. So what I was trying to say is quality in terms of it should be driven towards your application. For instance, if you're applying to medicine, it should be towards that. If it is towards family medicine, it should be towards that. And if it is peds or OBGYN, psychiatry. So that's probably the first priority. But the goal before applying to residency is to have as much as you can. So here, probably quantity is more important. But at the same time, if you're able to have a couple of the presentations, or excuse me, the research, it is towards a specific factor. So if you're working on a specific interest and it's always been repeated, for instance, let's say if you're interested in sickle cell, now you're working first on stem cell, working on the quality factors. So you're having about 3 or 4 things that you're focusing on, which is showing a clear interest in a specific topic. So I would say probably quality, or excuse me, the quantity first, but at the same time, if you're able to work on quantity, it will make your CV shine a bit more, especially with institutions or universities.
I see. Thank you, Dr. Mulham.
You're very welcome.
Again, thank you so much, Mohamed, and always a pleasure to have you. Go ahead, Sarah.
First, thank you, Doctor, for this great session. My question is, if your presentation experience was outside the research presentations, is that considered a plus in the CV in such interviews?
Sorry, Dr. Sarah, I wasn't able to hear that. Can you repeat the question again?
I said if the presentation experience was outside the presentations that's related to the research, like you have presentation experience but not related to the research, does that give a plus in such interviews?
So you're having, so from what I understood, you're trying to say is you did some research but are not related to the ones you're doing right now?
No. I have some presentation skills, but it's not related to the research.
Yeah, that's totally okay. So, so presentations generally is considered to be a skill, which means that you're a good candidate in terms of professionalism. So the more you do in terms of presentation, even though if it's not related to the research, it is still considered to be a good factor because not everyone would have presentation skills.
Thank you, Doctor. Okay.
Also, doctor, I'm sorry, but actually I wanted to ask you about something more logistic. Right now, like, is it a real, like, is it a basic, like, requirement in the ERAS application to provide an MSPE? Because right now, like, and all what's happening in Sudan, I don't think that we can provide, like, we are working, of course, towards that, but I don't think that we can actually be able to provide MSPEs. So what do you suggest that we can do regarding that?
Yeah, I think what you're saying right now, Dr. Hayam, it's a really important point. And you brought it early. That's a good point to bring. So at the moment, I don't think that IRAS or RMP are aware of it. They might be seeing the news, but they're not aware of the whole situation. So it's better to start early. So it won't be easy to get MSPs at the moment. And it's considered to be one of the factors that they look for in most programs. So I would highly recommend reaching out and trying to get all the ones who you think that they're going to have a problem in that. So getting the bigger numbers is always important, and mentioning it to the NRP that it's going to be a problem based on how the situation is going on right now in Sudan. And the probability that we will be able to get MSP is less. So it's going to impact poorly the matching process. And there will be great applicants that will be missed if they don't have that exception, because they can do exceptions at times.
Mm-hmm. So it's really necessary. I have to just prepare. We have to actually.
It is.
No way around.
Yeah,
okay.
I think so.
Okay, so I have also another question. I wanted to ask you about the program list, like how to prepare my program list. There are some like program lists that are roaming around in the groups. You can see like program list for IM residency programs and others. But some people, actually, I heard some people that might recommend some applications to actually customize your program list. Would you like suggest, shall we like make our own program list from the application, or just search it from either Frida or something else? Or shall we get the applications like Matter Resident and the other applications to make it more customized for our features?
Yeah, I think I got your question. And when I applied about 2 years back, I had almost the exact same thing. So it's always happening almost every year. And I believe that the list is really good, but unfortunately, it does miss good programs that you might fit better. The only person that can determine if you are a good fit for a program or not is yourself. Like, you need to go through Frida and go through the most likely every site and see exactly if it is working, like, or excuse me, the website for the program, and seeing if it is appropriate for you or do you fit there. So you're looking towards certain factors there when you're reviewing the website. Most of the programs, they're repeating themselves. They're saying we are this and that and this and that. But the reality is you're trying to see the interns. What is the proportion of interns or residents that there? Are they IMGs or American grads? If a program, let's say, is getting like 75% or 90% American grads, the probability is less likely to get us there, because it means that they choose or they have strict rules to get IMGs into the program. So your goal is to have somewhere like maybe 50% or more, unless the only exception to the rule is if you know somebody there or somebody's going to recommend you. So then that changes the rule a bit. But generally speaking, yeah, I would recommend highly Farida.
Farida, okay.
Yeah.
Okay, thank you, doctor.
You're welcome.
Thank you, Doctor, for the presentation. I have a question about emailing programs. I heard some people recommending emailing programs to show your interest, like indirectly through maybe asking certain questions about the program, maybe even as early as June, so you can sort of establish some sort of connection with the program. What do you think about this, or would you advise against emailing programs as like this early?
Thank you, Dr. Marsan, for the question. I think that's an important question, and I think you can start as early as right now. It's a good time to start early and to let them know that you're interested. And you can ask them if they have opportunities for observership or electives, especially if you are in the same city. That will increase the chance. And always mention your CV, the most important factors. Usually programs are looking towards certain parameters. They look for if somebody is a citizen or having green card, or at least other factors. So you're trying to mention the things which will shine out. So not requiring a visa is a plus, but also trying to mention that you're involved with MSU as a research fellow, and you have published a couple of publications, as well as you have done some exams. For instance, you're done certified, but also if you're done step 3, add that. So that will shine a bit, and they might place you in their review in the committee. So it can come as early like right now, maybe May or June, and they might place you in the list which are the interesting applicants. I remember once, I'll share my own experience about that. So I sent a lot of emails to programs, especially the ones that I felt that I'm having more of a chance to get an interview. So one of those situations, I remember one of the programs was like, you're in the same city, why not come just check out our program? Now, they said that because they felt that I'm an applicant based on their CV, I'm well suited for the program. So that can always create a chance, you never know. So it's just luck, and all we need is one interview to match. So you can start as early as today, just see the programs in the city that you're living in, and try to send as much as you can. But at the same time, make sure you review the message or the email. It should have no grammar mistakes as much as you can. It should be professional, like dear Mr. or Mrs., last name, and then going towards all the professional manner, subject-wise, content-wise, and the ending. And try to attach your CV as well, because also that's critical. And we allow them to review your CV and might give you an interview. Many times, applicants are not able to start residency during this time, so they might offer an interview. It can be a chance.
Okay, thank you very much, Doctor.
You're very welcome.
Hello, Dr. Mulham. Hello.
Go ahead.
Thank you for for all the informations. I'm a recent grad. I graduated in the 2022. I wrote my step 1, and now currently I was hoping to do my step 2 next month, but due to the Sudan situation, as I did my step 1 as a student, so I need the status verification from ECFMG all over again. I was hoping to apply for the coming March, and I don't know when I can do the status verification and then to be able to sit for my exam. So some of the old residents, they told me that you can apply for the match without the step 2. I mean, and then you can follow the step 2 later. So is that something that's possible? Thank you.
Thank you, Dr. Rafisa, for the question. I think that's really a good question. So one good thing you mentioned right now is, actually, it's a huge factor. You are a recent grad, 2022. So that changes the whole game for you. So it's better to apply this year, but at the same time, your goal is to, if it is step 2 CK, I guess it should be a high score. So that's the only thing. And you pass, I guess, step 1. That's what I understood. So that's a good thing. You're trying to work on all the factors, research, and all the things, but the priority is to pass the exam. You can apply this year. There's one thing to remember, that the probability that you get a large number of interviews is less, but at the same time, you might be getting 2 or 3 interviews, which might be sufficient to match. So it's always good to try. At least this year, I guess it's going to be good to apply with that. Hopefully the MSPE is also resolved as an issue. And trying to get letter of recommendations is going to be a bit critical in terms of timing. That's the only thing. It's going to be stressful because you're going to need to work on your personal statement, the exam, and a lot of factors to make sure that you're ready. But if you're thinking that you're going to prepare everything in the right timing and everything is all set, then I would say 100% go for it. And hopefully you have multiple interviews and match as well.
Thank you very much. I also wonder that like if I was not being able to to write my step 2 exam until maybe September, is it also still possible for me to apply?
Yeah, I do think so that you can apply September. So I would share, I remember like many of my friends 2 years back when they applied, they didn't have their ECPMD certification at the time, but they still matched. They had probably about 2 interviews or 3 and they matched. At the time, we used to take the CS. So we had step 1, CK, and the CS. So he finished his step 1, CK, he scored well. I think he was like 3 or 4 years grad from school. Applied, got their interviews, went to the interviews, and they were like, we would need your CS to be certified and to rank you. So the programs can give interviews to applicants, but the only problem is they can't rank unless you are ECPMG certified.
Right.
So yeah, so the goal is before the ranking timing that you have actually that part, ECPMG certification.
Inshallah, thank you so much.
You're welcome.
Another question, Dr. Mulham. Actually, I was asking I was wondering that I heard some people say that step 3 sometimes increases the chances of you getting an interview. So especially when you take it and you get the results and you apply with it before the application season starts. So what do you like? What's your opinion about that? Does really step 3 make a change or might make like a difference in your application?
That's a very good question as well. So I would say that based on the data from the NRMP, so there's a lot of data there mentioning different things based on different fields. If it is medicine, family medicine, surgery, and different fields. So in medicine applications or residency, I would say based on the numbers that I recall, it's probably about 10 to 20% interest in programs. So the whole programs at the end of the match, they undergo surveys, and based on it, they would mention their preferences. So I would say probably about 10, 20% of the programs really consider that, and they give interviews based on it. But it's not the only factor they would look into. So they would look at your application as a whole, and step 3 could be a factor that would change your CV in terms of, let's say, so why it's important in some applicants when they apply, it's the factor is mostly based on step 1 or the CK. If, for instance, we didn't achieve the scores we're aiming for, that's above average, then step 3 will make it look better. Because what does step 3 mean? Step 3 means you're able to pass the board. Now, the goal of every program is to have applicants that they're considered to be professional, as well as they're able to pass the board. That's a priority. So if you're able to pass step 3, it's kind of like a factor for them that you're definitely going to pass the board. So about 10 to 20% of the programs will be interested in seeing that.
Mm-hmm. Okay, so does step 3 score really matters, or do I just have to pass it, or what do you suggest regarding that?
I'll also return back to the NRMP report. So score-wise, it depends. So if you're interested in having a fellowship as a next step, so it's always good to have a certain number, like above average. If you're able to take an exam, always the goal is to score as high as you can, not to rush it. So that's my recommendation. Like if you're going to take it and rush it, you might fail, and that's even worse. So the priority is, if you're going to take it, give it 100% focus, get a high score, and that will help in the application overall. But if we're speaking in terms of score-wise, in terms of residency, usually they don't look at the numbers that much. They'll just always look for pass. But if you score high, it will look much, much better, because getting a 230s, 240s, it means you are at a different level. You're definitely going to pass the board. that's what they would think about.
Mhm. Okay, I see.
Thank you so much. Thank you
You're
so
welcome.
much, Dr. Mulham, for your input and your information, your tips. This is great. Thank you for your time. And I really appreciate if you want to share your contact. If any other fellows have more questions, they can contact Mulham or myself, and we can try to answer your questions. I really appreciate you coming over, Dr. Mulham. Thank you so much, and talk to you later. I appreciate it.
Thank you, Dr. Nader. I appreciate
you.
that. Thank you for having me.
You're welcome. Next, we will go to Dr. Sushma. If you are ready, you can go ahead. Have a wonderful day, Dr. Mulham. Thank you.
You too. Thank you.
I have another question for Dr. Mohamed, if it's okay.
Dr. Mayra Ashraf, or
Yes, Nada Ashraf.
okay, go ahead.
Thank you. Doctor, I just had a question regarding, for me, it's going to be my 5th year since graduation this year. So I just wanted to ask if I entered with step 1 and step 2 only, even if I have a high score in step 2, without any clinical experience there in the US, should I apply this year, or should I like make my CV better and take step 3 and take more experience in the US before applying? Or should I just do it because it's like my 5th year? Does it matter? Or should my CV be more like strengthened first?
Yeah, so I think programs usually they have a cutoff phase. So every program they have their own parameter they look for, or the factor that they use for as a cutoff. So I would say most of the programs they do have a 5-year cutoff. So if you're in the 5-year already, so it's good to try, because then you won't be thinking about it the whole year, like you missed on a chance of applying and getting an interview. So I would say highly recommend, try to apply this year, try to get some electives or clinical experience. If you can, maybe 1 month is sufficient, at least getting letter recommendations. But if not possible, still try to apply, try to choose the programs which have less interest in terms of like clinical experience. Most community programs will be definitely focusing on that, but university programs and institutions would, they're still interested, but they're less likely to be looking at it as a factor. They're more interested in academic profile. And good luck.
Thank you, doctor. I just had another question. For me, I'm going to apply for radiology because all of my experiences within diagnostic radiology. And for telerotations, is it like the same with clinical experience, or is it different? Like it's a different level, so I should do like clinical experience there in the US. It would be too much difference between the both of them.
Yeah, I think there's a difference there, but it's all based on how much time you have in your hand. And if, let's say, you think that you're not going to able to get clinical experience, so then it's the best thing is to have a tele. At least you have something in your hand while you apply. So see what you can do. Like if you think you're going to have time for clinical experience, then definitely go for it. But if not, then definitely go for the tele. At least you're going to have something to speak about and to mention that you have an experience. But it's not the same in terms of equivalence.
Yes, I understand. Thank you so much, doctor, for your valuable information. Thank you.
You're very welcome. And good luck, everyone.
Thank you.
Thank you so much, Dr. Mulham. We really appreciate the input of this, and thanks for the advice. Have a great day. Sushma, when you are ready.
Yes, Dr. Nader. Good morning, everyone. Sorry, good afternoon, everyone. So, yeah, first of all, I just want to say thank you so much, Dr. Nader, and my team, Dr. Noreen, Dr. Ravia, Dr. Ryan, for for helping me prepare this poster, and they really did a great job, and I want to thank Dr. Nader for giving me this opportunity. So I presented this poster at APA, that's American Psychiatric Association conference in San Francisco last week. So our topic was usage of mobile application in behavioral health. It was a systematic literature review and future research directions. So I'm sorry, I've joined on my phone because I'm outside. So I've shared my poster with Dr. Nader, and I'll share it with everyone once I get home. So basically, this poster presentation went really well, and everybody was very interested in this topic, especially because they had they had a session about mobile applications and its use in mental health. So it was related to that. So everybody were very interested. And also, like most people nowadays use Fitbit app and they use Apple watches. So they were like very interested to know our findings. But yeah, like we all know, none of the apps are very effective, and they need more research and more work to be done. So that was the takeaway message from our poster and from the interactive session, and from whoever attended my poster presentation. So one thing that really helped was during my poster presentation, what I did was one thing that I would recommend for future poster presentations as well was I used a QR code, which in which I put in the reference section, then our affiliations, and about our the geriatric fellowship experience as well. So this kind of helped make my poster less cluttered, and that was something that like a lot of people noticed and appreciated. And a lot of people were interested to know about this geriatric fellowship, and quite a few people asked me what it was, and what we really do, how often we meet, and how we learn and stuff. And many people were even like program directors. So that kind of that a lot of people took notice about the fellowship and the experience in general. So yeah, these were my experiences. One thing I wish I did differently was I didn't have time to add pictures. So I feel like maybe next time in my poster presentation I would definitely add more pictures and more tables, and so it's easier for people to read and understand. Yeah, thank you. Thank you for the opportunity again, Dr. Nadir and team.
Thank you so much, Dr. Sushma. This is great. Thanks for sharing your experience, and thank you and your team for doing all this, and congratulations. Hopefully it
Thank
will
you.
help you in your application and the other team application.
Thank you, Dr. Nadir.
Mayra, you can go ahead.
Hello, everybody. Well, we're going to start with the presentations now. I'm going to share my screen. Share. And the first theme, we're going to speak about cardiovascular. We're going to speak about cardiovascular disease, part 2, and the doctor's presenting. If you can start. Is Dr. Hina, Dr. Lubna, and Dr. Heba, and Dr. Dalia. Well, girls.
Hello.
Mm-hmm.
Can you hear me?
Yes, we hear you.
Okay, hello, this is Samia Alajab, actually. Just a correction, I will be presenting the first part. Can you hear me, everyone?
Yes, I can hear you.
Yes, I do apologize. I'm having some technical issue with my computer, so I'm joining both from my computer and my phone. I'm not sure if I can, if I'm able to open my camera and then do the same, this in the same time. I'm not sure. So if you can see me or you can hear me well, please let me know.
We can hear you. We can see you.
We can hear you first.
Okay, thank you so much. I appreciate it. I will be starting the first part myself, and then Dr. Hina will follow me. Okay, so we will be presenting the second part. Last week, the first group already presented the first part of this. Okay. So the objective of this is like to be able to describe how the cardiovascular system changed with normal aging. I think the last Saturday in the last meeting, or they already discussed this, signs and symptoms of the most important cardiovascular disease in older patients, the appropriate diagnostic tests to identify the presence and severity of cardiovascular disease, and the standard for treating cardiovascular disease. These are our objective of this presentation. Okay, we can. This is the first part. The previous group already talked about the epidemiology of cardiovascular disease, effect of aging, cardiovascular function, cardiovascular risk factors, coronary artery disease, and acute coronary syndrome, chronic coronary artery disease. Today, me and Dr. Hina, Dr. Lubna, and Dr. Heba, we will cover the part regarding valvular heart disease, cardiac arrhythmias, and peripheral arterial disease. Thank you, Dr. Mayra. So for types of valvular disease, we're going to talk about aortic stenosis, aortic regurgitation, mitral stenosis, mitral regurgitation, and okay, and all right, 1 second, I'm sorry for that. Okay, so the prevalence of aortic stenosis increases with age. It get to around 15% in the up to generian, like people 80 or more. There will be increase in the incidence of aortic stenosis. It's also the most common type of valvular abnormality requiring intervention in older adults. Aortic regurg also can happen in adult. It could be acute, it could be chronic. The incidence of both cases increase during with age. As patient age, aortic regurg can also increase. It's usually severe enough, not like severe enough like aortic stenosis to require like surgical intervention. Another thing is that rheumatic heart disease, like rheumatic regarding mitral stenosis, rheumatic heart disease is uncommon in older adults, especially here in US. It's a developing country issue, but occasionally patients in their 70s, their 80s can present with symptoms attributable to previously undiagnosed rheumatic disease. Disease can be diagnosed incidentally. It can, like the patient would be undergoing an echocardiography for any other reason, like let's say a new onset atrial fibrillation. The patient will go for echocardiography and they will be discovered that the patient having mitral stenosis. More commonly, mitral stenosis in older adults, it's most likely due to as I mentioned, non-rheumatic heart calcification of the mitral valve and annular subvalvular apparatus calcification also. So what will happen is that this will lead to narrowing of the orifice, decrease in the excretion of the valve leaflets, leading to mitral stenosis. Mitral regurgitation is also another thing that can happen. It could be acute also, it could be chronic presentation. It's in up to 1/3 of older adults can have mitral regurgitation. Only small proportion will require surgical intervention. Okay, can go to the next. Okay, so diagnosis of valvular, I'm sorry, I'm not following. So you have to go, diagnosis of valvular, sorry for that, guys. So the diagnosis of valvular disease mainly by echo. So echocardiogram is the procedure of choice. Echocardiography with Doppler can non-invasively assess the causes and the severity. For example, in aortic stenosis, the echocardiography will, where certain measurement can show the severity of the disease, evaluate the left ventricular function. It can determine the presence of other like valvular lesion associated with it. Like in severe aortic stenosis is indicated by the maximum aortic jet velocity. So when they do these measures through the echocardiography, if the aortic jet velocity measurement are more than 4 meter per second. This is considered severe. Or the mean transvalvular pressure gradient, measurement of that also. If it is 40 or more millimeter mercury, this means severe aortic disease. And other thing is that aortic valve area, the aortic valve area, if it is like less than 1 square centimeter, this is also considered severe aortic disease. So echocardiography will look at the severity of most acute and chronic valvular abnormality. It also provides important information about left ventricular size, left ventricular function, left atrial size. If there is pulmonary hypertension, it will also you can be able to measure the pulmonary artery pressure and presence and severity of other valvular lesion. For mitral stenosis, it's like the considered diagnostic, actually, like echocardiography is diagnostic. It will give you the definite diagnosis for mitral stenosis. Also, it can tell you how severe the mitral stenosis, and if there is any other valvular lesion, you can look for other valvular lesion with it, the severity of it. For mitral stenosis, also mitral valve area less than 1.5 square centimeter can also mean that there is a severe mitral stenosis. Transvalvular gradient of 10 or more, this is also considered severe mitral stenosis. Okay, so the next aortic stenosis. So aortic stenosis, so symptoms-wise, the patient will be presenting with, we all remember the sad mnemonic, so the syncope, angina, and the dyspnea. So the angina is like due to decrease in arterial blood supply to the heart, dyspnea on exertion, heart failure. The patient can present with lightheadedness and pre-syncope and syncope. For finding physical examination, it's going to be like systolic membrane. It would be mid to late systolic ejection membrane. That would be here in the right intercostal space to the right intercostal space, and also with radiation to the carotid area. There would be S4 gallop due to stiffness in the left ventricular wall. Left ventricular heave also because of the left ventricular hypertrophy. EKG will show left ventricular hypertrophy signs, or like it will give you left ventricular hypertrophy picture. Regarding treatment for aortic stenosis, so medically there is no effective therapy. Percutaneous transcatheter aortic valve replacement in selected patients at an intermediate to high surgical risk. So it depends on the patient risk factors. So aging, if the patient have other comorbidity, if the patient have other risk factor, cannot do any surgical procedure that will increase their risk. They have high risk. Transthoracic or transcatheter aortic valve replacement is the procedure of choice. Surgical aortic valve replacement or aortic valve repair indicated for severe aortic stenosis in patients with symptoms. Biprosthetic valve is always preferred in older patients. Biprosthetic is preferred when compared to mechanical valve. There is no need for long-term anticoagulation. Like in the case with mechanical valve, you have to put the patient for long-term anticoagulation. And biprosthetic, most of the patient can have the anticoagulation only for like around 3 months. And then this would put the patient in other risk. The biprosthetic valve, the bovine, the porcine one, is using like either valve tissue from the pork or like pericardial tissue. It's not the risk with it is that it's the same, like it's still tissue, so there will be tearing, there would be wearing and tearing. So with time, you might need another procedure, second procedure. But other than that, there is no need for lifelong anticoagulation like the risk with mechanical valve. And older adults who are going to be considered for aortic valve replacement should be always having coronary artery angiography first before they go to the procedure, because they say that there would be significant cardiovascular coronary artery disease in more than 50% of those patients. So they should be having coronary artery angiography before the procedure. Okay, and aortic regurgitation. So symptoms, the patient can be also presenting acutely or chronic. The patient also could be asymptomatic or minimally symptomatic. It depends on the severity of the disease. So in mild cases, it would be asymptomatic or minimal symptoms. And then for severe cases, there would be dyspnea on exertion. The patient can present with heart failure, angina in those severe cases. Finding for physical examination, there would be wide pulse pressure, and then bounding pulsation or collapsing bounding pulses. There would be also diastolic murmur, crescendo, decrescendo, diastolic decrescendo murmur. That would be best here in the left sternal border. It would be in the third intercostal space. And then systolic ejection murmur. So the most common is like to hear the decrescendo diastolic murmur, but systolic murmur is because of the aortic regurgitation will cause like overflow of blood through the aortic valve, so that could also give us systolic ejection murmur. And another thing is that ECG finding also would show left ventricular hypertrophy in severe cases and chronic cases of aortic regurgitation. In acute cases, the only presentation in the EKG or the thing that will appear in ECG is tachycardia. Chest radiograph would show cardiomegaly, severe and chronic cases of aortic regurgitation, and then pulmonary congestion and cases of acute aortic regurgitation due to backup of the blood in the line that will appear as pulmonary congestion chest X-ray. Treatment for aortic regurgitation, another thing is that here for medical treatment in less severe cases, there could be a possibility of use of medication. So control of hypertension, if the patient is hypertensive, preferably using dihydroprotein calcium channel blocker, angiotensin converting enzyme inhibitor, angiotensin receptor blocker, beta blocker in patients with symptoms of or left ventricular systolic dysfunction. Surgical repair for aortic valve regurgitation is indicated only for acute severe aortic regurgitation or patients who are symptomatic, having symptomatic severe coronary aortic regurg, or those with symptomatic severe coronary aortic regurg and left ventricular and the ejection fraction less than 50% or left ventricular and systolic dimension more than 5 centimeters. Okay, for mitral stenosis, so symptoms are gradually worsening. Another thing is that dyspnea on exertion would be presenting early, while orthopnea and leg edema will be presenting late. It's like when right-sided heart failure and pulmonary congestion happen, then later we will see leg edema. Progressive decline in exercise capacity. For finding for mitral stenosis, that the physical examination, the patient will have early diastolic opening snap, and then late pitch rumbling, diastolic murmur at the apex, pulmonary hypertension, right heart failure. For treatment for mitral stenosis, also medical treatment, diuretics, just like treatment of heart failure, so diuretics for volume overload, and beta blocker for decreased exercise tolerance associated with tachycardia. For other intervention, percutaneous or surgical repair. So percutaneous balloon valvoplasty, this is safe and effective, but most older patients are not a good candidate due to extensive calcification and commissural fusion or concomitant mitral regurgitation. So surgical mitral repair is effective, but with around 5 to 15% operative mortality in older patients. Another thing is that, again, if the patient is having mitral valve mitral valve stenosis and they are undergoing repair, mitral valve repair, they should be doing going for coronary angiography before actually the procedure, just because 50% of those patients, same like mitral aortic stenosis, they would have coronary artery disease. So coronary artery angiography should be done first before surgical repair. Okay, for mitral regurgitation, symptoms can be acute or chronic, and marked shortness of breath. Patient will be presenting with orthopnea in acute cases, severe mitral regurgitation, also progressive dyspnea on exertion in chronic mitral regurgitation. Physical examination, the patient would have pulmonary rale, pulmonary crackle, tachycardia, narrow pulse pressure, and there would be like Gallup PRISMA S3 and short, harsh systolic murmur. In the acute cases of mitral regurg, in the chronic cases or in mitral regurg, severe cases, it would be hollow systolic murmur radiating to the axilla, and then S3, Gallup, pulmonary hypertension due to congestion of the pulmonary vessels, and right-sided heart failure in chronic severe mitral regurgitation. Okay, so treatment for mitral regurgitation, medical treatment, medical therapy as for heart failure. So with systolic dysfunction, in patients with symptomatic chronic mitral regurg, they would be treated the same way as treating heart failure. This is for mitral regurg with left ventricular ejection fraction less than 60% who are not candidate for intervention. So medical treatment for patients who are not candidate for intervention. Intervention, also there is percutaneous and surgical intervention. Percutaneous is transcatheter mitral valve repair in selected patients, and surgical intervention is through mitral valve repair or mitral valve replacement. Mitral valve repair is like the preferred procedure because you are reserving the heart tissue, like especially if it is percutaneous repair. So you are reserving the heart tissue, so there is less side effects that are coming from the surgical replacement or like mitral valve replacement, like operative mortality are lower for those who are repaired than those for replacement. And another thing is that, again, bioprosthetic valve is a preferred over mechanical valve due to the same issue with anticoagulation, and then there is less risk of bleeding for older population, especially those people who have other comorbidities and they're taking a lot of different medication. All effective with 5 to 15% operative mortality in older patients. And again, mitral valve repair is preferred because there is less risk for complication after surgery. There is less risk of bleeding. There is also like rapid recovery for the patient. This is why it is preferred, and we are reserving the heart tissue and reserving the function of the heart. And older adults who are being considered for aortic valve repair again and mitral valve repair again should go angiography before the procedure. And anticoagulation usually for bioprosthetic will go for 3 months, and the goal is to keep the INR between 2 to 3 to be maintained between that. And after the 3 months, they would be considered for aspirin 75 to 100 milligram if the patient doesn't have other risk factor for thromboembolism. And mitral valve regurgitation, there are like criteria for patients who can go under surgical intervention. So surgical intervention indicated in which cases, like cases with urgently, it's indicated urgently for both for those who have acute severe mitral regurg with heart failure, for symptomatic patient with severe chronic mitral regurg and left ventricular ejection fraction more than 30%. Also, asymptomatic patient with severe chronic mitral regurg and left ventricular ejection fraction 30% to 60%, and or left ventricular and systolic dimension 4 or more centimeters. When mitral valve repair is deemed likely also to be successful in asymptomatic patient with severe chronic mitral regurg and on and a left ventricular ejection fraction of 60% or more. And then also in patient with severe chronic mitral regurgitation, pulmonary arteries, systolic pressure more than 50, or new onset atrial fibrillation with high likelihood of successful mitral valve repair. Okay, transcatheter aortic valve replacement. Transcatheter aortic valve replacement with bioprosthetic is associated with improved outcome relative to medical therapy in older adults who are not candidate for surgical aortic valve replacement. Short hospital lengths of stay, faster functional recovery with aortic catheter transcatheter aortic valve replacement. Vascular complication and stroke are more common after transcatheter aortic valve replacement, but major bleeding, atrial fibrillation are less common to happen. In patients who have high risk for surgical aortic valve replacement, transcatheter aortic valve replacement has demonstrated similar or better outcome up to at least 3 to 5 years, including risk of stroke, vascular complication, and all-cause mortality. And until recently, surgical aortic replacement, like surgical aortic valve replacement, was the only effective treatment for severe aortic stenosis. But now numerous studies have demonstrated excellent outcome for transcatheter aortic valve replacement after surgical aortic valve replacement and inappropriately selected older adults. So it's just the surgical repair is for appropriate for selected group of adults, including the people who are over 80 octogenarian. However, many older patients are either not suitable candidate for surgical repair due to other comorbidity, they have weaker heart, they have other comorbidity, or they decline the procedure. So some people just decline the procedure. They don't want to undergo like open heart surgery due to high preoperative risk attributable to comorbidity or frailty. Okay, then the last part I will be presenting is regarding infective endocarditis. So native valve endocarditis is the most commonly caused by either Streptococcus viridans or Staphylococcus aureus. Other species like Enterococci species, gram-negative bacilli are also common causes in older adults. Endocarditis very difficult actually to be diagnosed in older adults, and this is due to that fever and lymphocytosis are less common. So usually the patient will not present with like fever and high white blood cell count or anything like that. Another thing is that transthoracic echocardiography sensitivity is reduced by aging due to increased calcific disease and protective valve use on most patients. Other thing is that esophageal or echocardiography would be the useful one to use because it improves diagnostic yield for infective endocarditis in adult individual. And for those patients, since the early part of the 19th century, the 20th century, in the infective endocarditis has undergone a transformation from disease of young adult with rheumatic heart disease or congenital valve anomaly to one of older adult with degenerative valve disorder or prosthetic valve. So in the past, it's only for young individuals who have rheumatic heart disease. But since the 20th century, it's like, it's considered for older individuals with degenerative valve disorder or prosthetic valve disease. Less frequently, infection are due to the husk organism. So a group of gram-negative proteins that primarily inhabit the oral cavity. This include Haemophilus influenza, Actinobacillus, Cardiobacterium, Echinella, Kingella, or these bacteria known as husk organism, or other atypical pathogen also can be involved. Coagulase negative staphylococci, staphylococcus, one of these are common cause of prosthetic valve endocarditis, particularly in the first 60 days of valve replacement. And then transesophageal echo improve the diagnostic, as we said here, for infective endocarditis, but sometimes it might lack the positive finding on transesophageal echo. That does not mean it excludes infective endocarditis, so it still could be a diagnosis. Another thing is that infective endocarditis treatment is usually with intravenous antibiotics, so it should be given for 2 to 6 weeks. Surgical therapy should be considered for certain condition. First, in the presence of severe valvular dysfunction, or there is evidence of persistent infection despite appropriate antibiotic therapy. Patient with recurrent emboli or marked heart failure, myocardial abscess formation, high degree of AV block, or vegetation that are more than 1 centimeter in diameter on the left side, or left-sided heart valve, or fungal endocarditis. So recommendation for preventing endocarditis after dental procedure, focus on providing prophylaxis only in the highest risk patient. So those with patient with prosthetic valve, or patient who had prior infective endocarditis, certain congenital heart disease, so mainly cyanotic heart disease and that an unrepaired cyanotic heart disease, or a patient with cyanotic heart disease who was like undergone repair, but they still have symptoms, or like they have functioning, like there is still like ongoing symptom, or they undergone repair but fail, or also patients with cardiac transplantation with valve disease, like who underwent heart transplant, or they have valve lesion. These are the patients who are considered for antibiotic prophylaxis. And the recent guideline have eliminated recommendation for prophylaxis for those who undergoing like GI procedure or genitourinary procedure. So not any procedure, unless they have an infection, like for GI procedure, genitourinary procedure, unless there is an infection, there is no longer prophylaxis recommended. So mainly it's for dental procedure, or like any procedure involving mucus, like if it's gonna happen, like mucosal injury, like dental procedure dealing with the gum or the gingival manipulation, these kind of procedure that will the patient will be given like a card, and they will be having antibiotic like 30 to 1 hour before the procedure. And the antibiotic choice depends on the patient ability. If the patient is able to take an oral medication, so oral ampicillin before the procedure. If the patient is not able, they will just go with intramuscular or intravenous. So ampicillin is a drug of choice for oral, and ampicillin or ceftriaxone or other IV if the patient is not able to take an oral medication. Also for those with allergy to penicillin, erythromycin, and other medication are other option. So depend on the patient, the dosing and the route of giving the antibiotic depend on the patient. So this will end my part. Thank you, everyone. And Dr. Hina, I think it's
Yeah, thank you so much, Dr. Samia Alajab. That now is the turn of Dr. Hina with cardiac arrhythmias.
Yeah. Hi, everyone. Thank you so much, Dr. Nader, for this opportunity. So I will discuss here about the cardiac arrhythmias. So as we know that cardiac arrhythmias is basically the irregular heartbeat, or it is a problem with the heart rate or the rhythm of the heart. So it's normal for the heart to either speed up during the physical activity or to slow down while resting or sleeping. So most of the arrhythmias, they are either harmless, but they may be the sign of more serious heart conditions. So, but the most common causes of arrhythmias are either they have previous heart attack, any change in the heart structure, diabetes, high blood pressure, infection with COVID-19, or hyperthyroidism. But there are some age-related changes in the cardiac conduction system as well, which is coupled with increased prevalence of CVD at the older age. So it leads to progressive increase in the incidence and prevalence of conduction abnormalities and disturbance in the heart rhythm in older adults. So age-related degenerative changes in and around the SA node or an AV node, they increase either the bradyarrhythmias with the increase advancing age. Next, please. Mayra, next slide. Okay, thank you. So atrial fibrillation. So the most common sustained arrhythmia seen in the clinical practice is atrial fibrillation. So incidence and prevalence increase exponentially with age, such that the prevalence is octogenarians in approximately 10%. So among older adults with valvular heart disease or heart failure, the prevalence is even more higher when it approaches about 30%. So symptoms which are related to atrial fibrillation, they are highly variable. The most common are either palpitation, shortness of breath, impaired exercise tolerance, dizziness, fainting. So in patients with ongoing atrial fibrillation, the standard 12 lead EKG, it is diagnostic. So other studies should include echocardiogram, serum electrolytes, especially the potassium and the magnesium, and thyroid function test as well. Further evaluation in selected cases may include a chest radiograph, several cardiac biomarkers, BNP level, D-dimer level, lower extremity venous Doppler study, and evaluation for the pulmonary embolism. Next, please. So management of atrial fibrillation. So also objectives include relieving symptoms and minimizing the risk of thromboembolic events, particularly the stroke. So principal strategies for relieving symptoms are either control of the heart rate or maintenance of the normal sinus rhythm. So patients who experience significant shortness of breath, fatigue, or exercise intolerance that attribute to atrial fibrillation, they may be best managed with antiarrhythmic drug therapy, which is aimed at maintaining sinus rhythm. Next. And the alternative can you mute, please?
There's one.
عندها صورة أشعة كده باختصارها بعد ما انتهت الدكتورة قامت قالت للدكتورة إنه أمها كل يوم دايرة تاكل لحمة قامت قالت لها يعني بتاكلي كم للمرة بتاكلي يعني كل يوم
دعاء
Thank you.
Thank you. So the alternative to antiarrhythmic drug therapy for maintenance of sinus rhythm. So it is either catheter ablation of arrhythmogenic foci, usually through pulmonary vein isolation, and the surgical maze procedure. So all older patients with paroxysmal or persistent atrial fibrillation, they require consideration for stroke prophylaxis. Next. So management of stroke risk stratification. So CHADVAS score, so most accurate than CHAD-S2 for identifying the low risk of stroke. So it includes 2 points for age more than 75, 1 point for age 65 to 74, 1 point for
كل يوم لحمة هناي كل يوم لحمة بتاعت قوت هم ذاته ما هو بياكل
and 1 point for female gender. Score of more than 2, patient is a candidate for systemic anticoagulation. So HAS-BLOOD, its score, may be more useful for adjunctive tools to promote the informed decision making by estimating a patient's annual risk of major bleed. Next here. So management of atrial fibrillation and stroke prophylaxis. So warfarin titrated to maintain an INR of 2 to 3, aspirin 75 to 325 milligram per plus minus clopidogrel. So the ACTIVE-W trial demonstrated the superiority of the warfarin to the combination of aspirin and clopidogrel in terms of both risk of ischemic stroke and major bleeding in patients with atrial fibrillation. Then direct oral anticoagulants. So it is for the correct, we can see the table 50.4 for the characteristics and dosing of 4 docs available for the prevention of cardioembolic events in patients with AF. For AF patients with elevated Chadwick score in whom chronic anticoagulation is contraindicated, then consideration should be given to percutaneous left atrial appendages closure via the Watchman device. Next. So from here, I will give it to Dr. Lubna. Thank you so much, guys, for hearing me. And thanks for Dr. Lubna as well. Thank you.
Thank you, Dr. Hina. Good afternoon, Dr. Nadir, and good afternoon, everyone. This is Dr. Lubna. I will talk about other supraventricular arrhythmia. Atrial flutter usually occur in older patients with concomitant with atrial fibrillation. And both anticoagulation and rate controlling consider are similar to the atrial fibrillation. So, patient with typical atrial flutter that is either symptomatic or refractory to pharmacologic rate control should be considered for catheter atrial flutter ablation. And this is class 1 recommendation. The next one is atrial tachycardia, atrial ventricular nodal reentrant tachycardia, and multifocal atrial tachycardia. Treatment underlying this condition provide pharmacotherapy aims, rate control, or arrhythmia suppression. In selected patients with recurrent symptomatic episode, antiarrhythmic medication or catheter ablation may be considered in those patients. This is for supraventricular tachycardia. For ventricular tachycardia, frequent ventricular premature beat, ventricular couplet, and short run of non-sustained less than 30-second ventricular tachycardia. No need for therapy unless the patient is highly symptomatic, in which case the drug of choice is beta blocker. Longer episode of ventricular tachycardia with dizziness or syncope, those may need referral to cardiologist or electrophysiologist for consideration of antiarrhythmic drugs therapy or catheter ablation or implantation of cardiac defibrillator as a prevention. So for bradyarrhythmias, patient with mild bradyarrhythmia, which is a resting heart rate from 50 to 60 beats per minute, are often usually asymptomatic. Patient with more marked bradycardia, those resting heart rate from 40 to 50, may experience fatigue, lightheadedness, especially when standing, or reduce exercise tolerance. Pre-syncope or syncope may occur in patients with profound bradycardia, and those with heart rate less than 40 or systolic pulses more than 3 seconds. This may be due to sinus node dysfunction or heart block with the AV node or infranodal conduction system. So, how we can diagnose bradyarrhythmias? First of all, exclude the significant electrolyte abnormality, measure of thyroid function test to exclude hypothyroidism, and review the medication, which is most common cause of bradyarrhythmias. For those and for with unexplained pre-syncope or syncope, carotid sinus message to evaluate for carotid hypersensitivity as a cause. How? An abnormal response to carotid massage is defined as vocal reproduction of the patient's symptoms, like syncope, asystole more than 3 seconds, or decrease in systolic blood pressure more than 50 in absence of symptoms, or more than 30 in association with symptoms like dizziness or breathing. If symptoms occur daily or almost a day, every day, we need for 24 or 48-hour ambulatory monitor may be helpful for confirming or excluding bradycardia or other heart rhythm disorder as the proximate causes. In patients whose symptoms occur at least once a month, but not daily, we need for a 30 days event monitor may provide definitive diagnosis. For those with rare, less than monthly, but recurrent symptom of a serious nature, like syncope with injury, may need implantable loop recorder may be considered. So, how we manage bradycardia? Firstly, correct that any treatable causes like hypothyroidism and eliminate potentially offending medication if possible. In patients with confirmed symptomatic bradycardia, not amenable to conservative management, permanent pacemaker implantation is warranted. From here, I think Dr. Heba will continue.
Yes.
Thank you, everyone.
Thank you, Lubna. Hi, everyone. My name is Heba Elabadi. I will going over the last part of the presentation, the peripheral arterial disease. Encompasses disorder of the abdominal aorta, renal and mesenteric arteries, iliofemoral popliteal arterial tree. Prevalence increase with age and is higher in men than in women. Risk factors include hypertension, diabetes, cigarette smoking, and to a lesser extent in older adults, family history. Next, please. Peripheral arterial disease diagnosis. At least 50% of patients with peripheral arterial disease are asymptomatic or attribute their symptom to another disorder. Formal history and physical examination to screen for symptoms and signs of peripheral arterial disease is recommended for patients 50 to 69 years with risk factors for atherosclerosis, and for patients 70 years or older with or without risk factors. Men more 60 years or older with a family history of aortic arterial aneurysm, and men 65 to 75 years who have ever smoked should undergo abdominal ultrasound to screen for aortic aneurysm. Peripheral arterial disease treatment. The medication will be first aspirin 75 to 325 milligram. Clopidogrel is recommended as a responsible alternative to aspirin in selected patients. Combination of aspirin and clopidogrel may be considered in patients at a high risk of vascular event and acceptably low risk of bleeding. And ACE inhibitors or angiotensin receptor blocker for prevention of cardiovascular event is responsible in patients with symptomatic peripheral arterial disease. And patients with leg peripheral arterial disease should exercise regularly. Revascularization is indicated for patients with severe symptoms attributed to peripheral arterial disease that have not responded to aggressive risk factor modification, exercise, and pharmacotherapy. Revascularization is also indicated for patients with critical limb ischemia defined as wrist pain, ulceration, or gangrene. In this context, revascularization has been shown not only to improve symptoms, but also to reduce the likelihood of subsequent amputation. The management of aortic artery aneurysm. Indication for aortic artery aneurysm repair, development of symptoms, rapid aneurysmal dilatation detected during serial assessment, 1 centimeter or more in 1 year, and aneurysm more than 5.5 centimeter in diameter. Patient with asymptomatic aortic aneurysm from 4 to 5.4 centimeter in diameter should undergo repeated evaluation at intervals of 6 to 12 months. Choice of open or endovascular surgical repair of aortic aneurysm is based on location of the lesion and patient comorbidities and prognosis. Shared decision-making in cardiovascular disease. Shared decision-making entails patients expressing their preference and values, and clinicians providing relevant details of the risk and benefit of treatments. Patient decision aids for ICD and LVAD implementation. This is for more information. Mayo Clinic decision. Okay, the summary of this presentation. Calcific aortic stenosis is the most common valvular abnormality requiring intervention in older adults. Surgical aortic valve repair is the standard treatment for aortic stenosis in healthier older adults, while transcatheter aortic valve repair is an effective alternative in older adults at moderate to high risk of surgery due to comorbidity, frailty, or other factors. Atrial fibrillation increases in prevalence with age, and more than 50% of all patients with atrial fibrillation are aged 75 years or older. Most older patients with atrial fibrillation respond to rate control medications plus anti-thrombotic therapy, but some require anti-arrhythmic drugs therapy or other interventions. The prevalence of peripheral arterial disease increases progressively with age, and peripheral arterial disease is a potent risk marker for concomitant coronary artery disease and cerebrovascular disease. Management of peripheral arterial disease should include appropriate treatment or hypertension, dyslipidemia, diabetes, and tobacco abuse in accordance with existing practice guidelines. Now the questions about the content of this presentation. Case 1. An 82-year-old man has been progressively short of breath with exertion over the past several months. He had been healthy throughout his life with no risk factors for cardiovascular disease. On examination, hemodynamic findings are normal at rest with no postural changes in blood pressure. Jugular venous and are distended 6 centimeters. There are bilateral pulmonary crackles. There's one cross pedal edema, but no calf pain or swelling. Next, please. Which one of the following should be ordered first for this patient? Spiral tomography, CT of the chest, transthoracic echocardiography, pharmacological stress test, or complete blood count. Which one? I think all of you go with the correct answer. Yes. Yes, the correct answer is will be echocardiography. The second case, an 84-year-old woman comes for a routine visit. She is concerned about the number of medications she takes and asks why she needs to take preventive medication for cardiovascular disease at her age. She had a small non-STEMI 12 years ago, but no cardiac symptoms since. Medications, amlodipine, atorvastatin, metoprolol, metformin, acetaminophen, aspirin. She usually walks up and down her block every day. She has been missing these walks more frequently because of fatigue. Examination, blood pressure, 130/80 millimeter mercury, heart rate 60 beats per minute. Recent lab result, hemoglobin A1C 7.5%, LDL cholesterol 80. Which I can say is the screen. Which one of the following is the most reasonable recommendation for this patient? Stop aspirin and atorvastatin, stop metformin, stop amlodipine and metoprolol, resume her regular walking program. All of you going with D. Yes. Resuming her regular exercise is the correct answer. Okay, the last case. An 88-year-old man comes to the office for a consultation. He has had progressive shortness of breath on exertion. He has recently had chest pain and dizziness when he walks. His surgeon says that he is too frail for surgery, but may be a good candidate for transcatheter aortic valve replacement. Which of the following should be considered in the management of consider management plan of this patient? Transcatheter aortic valve replacement may be less effective for patients who have concomitant mitral regurgitation and pulmonary hypertension. Gait speed less than 0.3 mils per second can be used to identify patients who will not benefit from TAVR. Patients with normal Falls-10 score are more likely to benefit from TAVR, or a risk score that incorporate medical measures are more useful than those that incorrectable frailty measures. Okay, the correct answer is A. This is a pick for patients who have concomitant mitral regurgitation and pulmonary hypertension. And this is the last slide in our presentation. Thank you all for all of you. Thank you, Dr. Nader. If you have any question, go ahead and ask. Thank you.
Thank you so much, Dr. Hina, Dr. Samia, Dr. Heba, and Dr. Heba for the great presentation about cardiovascular disease part 2. And if you guys have any questions, we're here to help. If no, the next topic is going to be presented by Dr. Nagla Suliman.
Assalamu alaikum. Hi, everybody. Today I'm going to present the PRISMA statement. Okay, first we will talk about introduction. The systemic reviews and meta-analysis are essential to summarize evidence relating to efficacy and safety of healthcare intervention accurately and reliably. So in previous years, reporters and authors were using abbreviations that quorum. So each letter has abbreviation, quality of reporting of meta-analysis, statement as reporting guidelines. And this reporting system was found to be unsuccessful before. So as a result, they made PRISMA statement. So PRISMA also, it has abbreviation. So P for preferred and R for reporting items for systematic reviews and meta-analysis, was developed soon after creating a better reporting system. The PRISMA statement consists of 27 items checklist and 4-phase flow diagram. The checklist includes items deemed essential for transparent reporting of systematic review. So PRISMA statement itself provides further details regarding its background and development. This here flow chart showing flow information through the different phases of systematic review. As I mentioned before, it has 4 phases. So first, starting by identification, that number of records identified through database searching and number of additional records identified through other sources. After that, they can do screening, number of records after duplicates removed, and lead to number of records screened and number of records excluded. After this phase, we will go to the third one, that eligibility, so number of full text articles assessed for eligibility and number of full text articles excluded with reasons. And finally, that the numbers that included in the study, so number of studies included in qualitative censuses and number of studies included in quantitative censuses, that means meta-analysis. So the PRISMA checklist, it has also, as I mentioned, 27 items. We will talk about the first one, that title means identifying the report as systematic review, meta-analysis, or both. The second one is a structure summary, that give structure summary including background, objectives, data sources, study eligibility criteria, participants and intervention, study appraisal and synthesis methods, results limitation, conclusion and implication of key findings, for funding for the systematic review and systematic review registration number. The third item is rationale, which is describes the review in the context of what is it's already known. And the fourth one is objectives, provide an explicit statement for questions being addressed with reference to participants' intervention, comparisons, outcomes, and study design. They are making abbreviation for this one as PICOS or PCOS. And item number 5 is protocol and registration. Indicate if a review protocol exists, if and where it can be accessed, such as web address, and if available, provide registration information, including the registration number. And the eligibility criteria that specify study characteristics, such as I mentioned before, that BICOS, COS or BICOS, length of follow-up, and report characteristics such as years considered, language, publication status, used as criteria for eligibility and giving rationale. Information sources describe all information sources in the search, that such as databases with dates of coverage, contact with the study authors to identify additional studies, and date last search. So item number 8 is search that presents a full electronic search strategy for at least one major database, including any limits used such that it could be repeated. And study selection that states the process for selecting studies, that is for screening, for determining eligibility for inclusion in the systematic review, and if applicable, for inclusion in the meta-analysis. And item number 10, the data collection process. Here they are describing the method of data extraction from reports, such as piloted forms, independently by 2 reviewers, and any processes for obtaining and confirming data from investigators. Data items list and define all variables for which data were sought, such as PICOS funding sources, and any assumptions and simplification made. Item number 12, that risk of bias in individual studies. So that describe methods used for assessing risk of bias in individual studies, including a specification of whether this was done at the study or outcome level or both, and how this information is to be used in any data synthesis. And summary measures that the principal summary measures such as risk ratio difference in means. And also we have planned methods of analysis, describes the methods of handling data and combining results of studies, if done, including measures of consistency for each meta-analysis. Risk of bias across studies. Specify if any assessment of risk of bias that may affect the cumulative evidence, such as publication bias, selective reporting within studies. Additional analysis describe methods of additional analysis, such as sensitivity or subgroup analysis, meta-regression, if done, indicating which were pre-specified. And study selection that give numbers of studies screened, assessed for eligibility, and included in the review with reasons for exclusion at each stage, ideally with a flow diagram. And this item 18 is study characteristics. For each study, present characteristic for which data were extracted, such as study size or BICOS, flow-up period, and provide the citation, also the location of the study. Item 19, risk of bias within studies that present data on risk of bias of each study, and if available, any outcome level assessment. And results of individual studies for all outcomes considered, benefits and harms present for each study, simple summary data for each intervention group, and effect estimates and confidence intervals, ideally with a forest plot. Synthesis of results that means present the main results of the review. If meta-analyses are done, include for each confidence intervals and measures of consistency. Risk of bias across studies that present results of any assessment of risk of bias across studies. Additional analysis give results of additional analysis if done, such as sensitivity or subgroup analysis, meta-regression. And item number 24, summary of evidence, summarize the main findings, including the strengths of evidence for each main outcome. Consider their relevance to key groups such as healthcare providers, users, and policymakers. Limitations. Discuss limitation at a study and outcome level, such as risk of bias, and at a review level, such as incomplete retrieval of identified research, reporting bias, and in the conclusion, provide a general interpretation of the result in the context of other evidence and implication for future research. And the last one in the checklist is the funding. Describe sources of funding or other support, such as supply of data for the systematic review and the role of funders for the systematic review. So in our conclusion, the overall aim of PRISMA is to help ensure the clarity and transparency of reporting of systematic reviews, and recent data indicate that this reporting guidance is much needed. PRISMA is not intended to be a quality assessment tool, and it should not be used as such. So while the aim of PRISMA are to reduce the risk of flawed reporting of systematic reviews and improve the clarity and transparency in how reviews are conducted, there is a little data to state more definitively whether this intervention will achieve its intended goal. This PRISMA explanation and elaboration document was developed to facilitate the understanding, uptake, and dissemination to the PRISMA statement, and hopefully provide a framework for those interested in conducting and reporting systematic reviews. It follows a format similar to that used in other explanatory documents. So thank you for listening. And I know it is not an interactive topic, but I'm trying my best to make it easier. And really thank you, Dr. Nadir, for giving me this opportunity. And thank you, everybody.
Thank you so much, Dr. Nagla, was great. For anybody that needs the checklist, we can put it on I can put the link on the chat that you guys have the PRISMA's checklist. And now for the last topic, it's going to be Dr. Asma about leadership. Dr. Asma, whenever you feel free to talk.
Thank you, Dr. Mayra. Can you guys hear me well?
Yes, we do.
Awesome, thank you. Okay, I'll be sharing my screen. Hello, everyone. I hope you're having a good afternoon. I'm Asma Mustafa. I'll be presenting leadership skills today. In our presentation, we will discuss what makes a good leader, why is having good leadership skills is important, the most important leadership skills, how can you build leadership skills, and how to showcase your skills, and also the types of leadership styles. Okay. So what makes a good leader? Effective leaders, they have the ability to communicate well, motivate their team, handle and delegate responsibilities, listen to feedback, and have the flexibility to solve problems in an ever-changing workplace. Employees seek these skills in candidates that they will hire, and strong leadership skills are also valuable for all job applicants and employers. It's especially important for us as healthcare workers because you deal with humans frequently, as your team members, as your employees, and as your patients. You need it as a clinician, as a research fellow, for example, for us in drafting, planning, and executing projects, and also in business. Even in our daily lives, in your household, as many of us are parents, and we require actually some leadership skills for that also. Okay, so next we're going to talk about the top 10 leadership skills. First, communication. So as a leader, you need to be able to communicate clearly and effectively, to explain to your employees everything from organizational goals to specific tasks. You must master all forms of communication, including one-to-one, departmental, and full staff conversation, as well as communication via the phone, email, video chat, or social media. A large part of communication involves active listening. Leaders should make themselves regularly available to discuss issues and concerns with their employees. Next is motivation. So leaders need to inspire their workers and go the extra mile for their organization. Just paying a fair salary, while important, is not enough motivation. There are other ways to motivate your workers. You may build employees' self-esteem through recognition and rewards, and you must also learn what motivates your workers best. Delegating is often looked at as a weak point, but it's actually not. It's important to delegate so you can be available for more important projects. It's also important to delegate because that entails a specific knowledge of your employees to know what their skills, what they're skilled with, and to give them assignment based on that knowledge. Positivity, a positive attitude can go a long way in an office. It helps create a happy and healthy work environment, even during busy and stressful periods. Trustworthiness. So employees need to be able to feel comfortable coming to you with their questions or their concerns. It's important that you demonstrate It's important that you demonstrate your integrity. Employees will only trust leaders that they respect. And by being open and honest, you also encourage them to give you to reciprocate. Creativity, learning to try untraditional solutions or thinking outside of the box. This will help you solve an otherwise unsolvable problems. It will also inspire or impress your employees to follow your lead, and for them also to think outside of the box and think in unconventional resolutions or solutions. Feedbacks for leaders, you should constantly look for opportunities to deliver useful information for your team members about their performance. You should also employees, they respect a leader who can provide a feedback in a clear but empathetic way. So it's also important to be open to receive feedback yourself. Build a confidence in your employees, clearly lay out expectation, coach your employees, and follow up with them. Responsibility is also important, as a leader should be responsible for both the success and the failure of his or her team. Therefore, you need to be willing to accept blame when something doesn't go the right way. If your employees see their leader pointing fingers and blame others, they will eventually lose respect for you. So accept mistakes and failures, and then devise clear solution for improvement. It's important for leaders to show commitment and follow through with what they agree to do. You should be willing to put the extra hours to complete an assignment as you ask your employees to do. So it's also important to deliver when you promise your staff a reward, such as an office party. You should always follow through. Flexibility is important, as mishaps and last-minute changes always occur at work. Leaders need to be flexible, accepting whatever changes come their way. Employees will appreciate your ability to accept change in stride and creativity and creatively problem solve. So how can you build your leadership skills? So first, take initiative. Look beyond the task that you're given in your job. Think long-term about what would be beneficial for your department and the company, and even yourself as a trait to have. Try to brainstorm ideas and commit to doing work that goes beyond the daily routine. Request more responsibilities. Ask, how can you help out? Are there upcoming projects that you can contribute to? Is there any work that you can take off your manager's list, for example? And then target specific skills. If you have a specific skill that you think you should focus on, let's assume it's creative thinking or communication, it's better to create a plan to improve your ability in this area. You can take classes, you can find a mentor to help you with this task, read books, or set a small goals that you can force yourself to develop this skill, like on a daily basis or on a weekly basis based on your schedule. Also talk to your managers, your coworkers, or even your friends outside of the office to help you develop a plan to improve. So now that you have the skills, how to showcase your skill on your CV? So first, list them on your CV. Describe specific cases on your cover letter where you demonstrated these skills. Be prepared to talk about them in your interview, giving examples of situations where a specific leadership skill was helpful to you and your team. Next, we're going to talk about the types of leadership styles. So the German-American psychologist Kurt Lewin, he was credited for branding the basic leadership style in 1939. Lewin and his team, they were tasked with creating a project for school children with an art and craft project, while the team observed their behavior and responses to different styles of leadership. The idea was to determine which style was most effective to use. Dr. Lewin identified 3 styles of leadership. The first 3, autocratic, democratic, and laissez-faire. Over time, one more leadership style have emerged, and that type is commonly grouped with Dr. Lewin's other 3 styles, and it's called transformational style. Let's talk about them in depth. So autocratic leadership. In autocratic leadership, the direction comes from the top. So a singular figure who has who is at lead of the company. So the autocratic leaders, they determine the strategy, the policies, the procedure, and the direction of the organization. They dictate everything, basically. Authoritarian leaders, they are not focused on collaboration with those in their circle. They are rarely interested in feedback, and they prefer to hold all the power and be in charge. This style is best suited for urgent or chaotic situation that require someone to be assigned as the leader or to assume this the leadership and make a prompt and effective decision. Next, the democratic leadership, or also known as participative leadership. This approach involves gathering input from your subordinates and team members, so everyone has a chance to contribute to this decision-making process. This approach allows others to feel engaged and have a stake in the final outcome. So this style is best suited for most situations where a creative input is required, and it often heightens the employee's morale. Next, we have the laissez-faire leadership. This is a French term. It means leave alone. So this approach involves empowering your employees, being hands-off, and trusting them to accomplish the task at hand without constant questions or micromanagement. Laissez-faire leaders, they have the decision they leave the decision, to their employees while staying available to provide feedback when necessary. This is best suited for when everyone in the team is equally skilled to the task in hand, and they feel empowered by a laissez-faire leader, and they would feel more accomplished when they complete their task without a guiding hand or directive. And the last one is the transformational leadership. Transformational leadership involves developing a grand vision and rallying your employees around it. Under this style, the team is eager to transform and evolve personally and professionally in order to achieve the overall goal. With the organization and employees aligned, teams work under transformational leader, and they are united for the singular cause, and they're willing to commit their effort, time, and energy for the goal. So in order to see clearly the vision and the goal for the organization, employees usually remain loyal, remain productive, while working to accomplish their mission for the organization and for themselves also. So this leadership styles usually creates harmony in workplace for everyone to work together, and the lines of communication also stay open between the employees and leadership. So which one of the 4 leadership style you think fits you and your job's culture best? Thank you, everyone. This was summarized, and I hope you benefited from it.
Thank you so much, Dr. Asma. That was great.
Thank you.
I hope you guys enjoy these presentations. And if you have any questions, we're here as the Lime team to ask any questions that you guys have. Thank you, everybody. I just want to, now we open for any projects updates, if anybody wants to share. For our team, we're working on the project of CBD and palliative care in the elderly population. Right now, we just finished writing the introduction, the discussion, and we're working in the methodology. Hopefully, we will finish in the next few weeks, and we will be able to publish our manuscript. That's what we're working in the Lime team. Yeah.
Excellent. Thank you so much. Anyone else wants to share their progress or ideas or updates about the products?
Hello, everyone.
Yeah.
Hello, Dr. Nadir. I hope you're having a good day. Actually, the neurology group that we are working on the systematic review. We are currently developing the protocol in order to get the review registered and get the registration number first. And then we're going to go ahead with the data collection and the other steps. Thank you.
Excellent. That's great. Anyone else? Go ahead, Dr. Samia.
Hello, Dr. Nadir. Thank you for the opportunity today, guys. And thank you for Mayra for being a great leader on support, very supportive with sharing. Dr. Nadir, I would like to ask for people like me who are eligible for pathway 6. And I do not have a lot of connection with doctors. How would like to know how we could reach out to doctors, and if there is any way that we would help us to find, like, at least I need 3 doctors to do a clinical assessment. So if there is anyone who have such an experience, who applied before through pathway 6, if he can lead us or can help us with that, or give us any idea about how to connect with doctors, how to make this easier for us. Thank you so much.
Thank you so much for the question. And I think they talked about it last week or the week before, but the idea is if you are in a state or city where there are some clinic, my advice is like there are free clinic, free care clinic. If you try to see if there are some in your area, most likely there will be attendance of physicians who contribute or spend some of their personal time there. So this might be a good approach to see if you can connect with them. The other way is to see clinics in your area, like primary care, family medicine, internal medicine, whichever where you want to go specialty, and see if you can contact the clinic and see if you can contact some of the providers there. The last approach is either to approach hospitals or maybe if you want to approach nursing homes, for example, see if there are some physicians who provide care there and they are willing to supervise you or just observe you doing some of the experience. There is another way to connect with, for example, if you are from Sudanese Physician Association. If you are from other group, you can connect to other group physician association or societies. Sometimes you might have the state physician association. You can contact them and see if there is anyone who can help. So there are different ways to approach this issue. Anyone else want to share their experience if you have other advice?
Thank you, Dr. Nader.
You're welcome. Any other questions? Any other updates, ideas? I know some of you they have a poster accepted or abstract. They are working on the poster, and some are working on some papers. Giuliani, go ahead.
Welcome, Dr. Nader. Hi, how are you and everybody? I'm asking about do you have like a timeline for the program? What are the requirements? So, for example, every 3 months, what should be achieved? What you have to do throughout the program?
So the program is flexible. It's not scheduled like every month you will do this, you will achieve, because it is different, and you have people who are certain times and availability. So our goal is to get you understand the steps for doing a research from start to end. If you know that in the first month, that's good. Sometimes it may take longer, but we want you to understand the steps. And if you have an idea, or if you have some team that started a project, you can join the teams where you can apply whatever you learned about the field of the research project. My suggestion is to finish at least one goal before end of the year, so that you can add that to your resume and you can discuss that with the interviews. The more projects you are involved in, the better. And the other time, if you want to work on your application improvement, let's say you want to do clinical observational skills or some to get some other recommendation letters, I recommend that you work on this right now as well. If you have extra time, you can work on your volunteer work. So the short answer is we don't have a timeline like you wanted to this to finish this by this time. We record all these sessions, so if you have extra time, you can go back to our recording and see what other people did in the last few years, how they accomplished things. The other option is to look at and share with you. For those who are interested, this is the website where you have the recent application of from this fellowship program. So we have different abstracts that are submitted. So what you can do, you can create a team and work on one of these, or whichever you think is pertinent to your career, and you can develop this from an abstract to a manuscript, for example. So a group of you might be working on getting this published as a manuscript or other, instead of just leaving it as an abstract, if that makes sense.
I see. So like I can recommend new like kind of studies or something like that.
Sure. Yeah.
Okay, that's good.
Thank you. Any other questions or any other comments? So one other innovation approach we are working on is getting more apps, like mobile applications for either phone, laptop, or tablet, etc. So if you are interested in developing some of these, we will be working on improving or learning about developing this app without going into the knowledge of coding and app development from technical point. We want you to know the idea that can help your patients if you develop certain apps with no background in coding. So there are some tools there. You can develop useful apps without coding. It's called no code app development, something like that. So if you're interested, you can talk to your team leader, and then there are some groups are working on different projects right now. We already developed one such app. And that's published in the IMR Guard app was published in Google Store. So can work similar to develop similar apps and so on. Any other questions? Any other comments? Any other any comments otherwise or updates otherwise? Right, Mayra.
No, thank you. And everybody, we are doing the Spanish classes every 2 weeks. If you guys want to join, yeah, we're there. We're learning the body parts. This is for everybody that is attending. Thank you so much. I really love to teach you guys.
Thank you so much, Dr. Mayra. I know Cabeza, I know Corazon.
Yeah. Yeah, we're learning it. We're learning. Cabeza, corazón, ojos. Oh.
Thank you. So if no other questions, then we will end this meeting. I'd like to thank you so much, Mayra. I'd like to thank all the presenters from today and all attending fellows. Thank you so much, and I wish you all the best. I will see you next week. If you have questions, please email me or send me a text. Assalamualaikum. See you next week.
Bye. Thank you so much for everything. Thank you. Thank you, Dr. Nader.
Thank you, Dr. Nadir. Thank you.
Dr. Nadir.
Thank you.
Thank you so much, Dr. Nadir.
Thank
Thank you,
you.
Dr. Nadir.
Thank you.
Thank you.
Thank you so much, Dr. Nader.
Thank you.
Thank you so much, Dr. Nadir.
Thank you.